Good morning, all. So today we are going to discuss an important but neglected disorders, that is mast cell disorders and mastocytosis. So to start the journey, let's talk about mast cell biology, the development and immune dynamics. So mast cell generally derived from CD34 hematopoietic stem cells in bone marrow, and they actually migrate to peripheral tissues in response to stem cell factor. Now, what happened? This stem cell factor will bind to the KIT receptor, the KIT receptor, the CD117, and I think we are going to discuss it more and more, this particular receptor, because all this pathology is centering over this particular receptor. And when they bind, this binding is critical for the health of the muscle, proliferation, maturation, migration, and survival of it. So, tissue microenvironment, the blood vessels, nerves, cytokines, all modulate local muscle phenotype and function. So, when we talk about the tissue, generally the skin, lungs, and gastrointestinal mucosa are the most important tissue resident cells. And as we talk about phenotype, there is one phenotype which is mucosal phenotype of mast cell. Generally, that mast cell produce or predominantly produce tryptase, whereas in the connective tissue phenotype, it produces both the tryptase and kinase in a good quantity. This is a classification, the phenotypic subtypes of mast cells. So as we were mentioning, the mast cell which are functionally and phenotypically diverse depending on their tissue localization and enzyme expression profiles. The two most well characterized subtypes in humans are one is tryptase positive only, that is the mucosal muscle, and another is the connective tissue muscle, where it is tryptase and kinase positive. So here we can clearly see the clinical relevance of mucosal muscles. Mostly it is important for allergic rhinitis, different types of aeroallergen responsiveness or food antigen responsiveness. It is increased during asthma or eosinophilic esophagitis, and mostly it is found in the mucosal tissues, as mentioned, respiratory tract and gastrointestinal mucosa. Whereas the tryptase and kinase positive muscles, the connective tissue muscle, they contain both the tryptase and kinase plus other proteases like carboxypeptidase A, and they reside in connective tissues, especially skin, submucosa, perivascular, and perineural spaces. Why it is clinically important? Because it is involved in chronic inflammation, fibrosis, tissue remodeling. And the major subtypes in cutaneous mastocytosis and systemic mastocytosis, this is the tryptase kinase positive one, and they are more resistant to degranulation compared to the tryptase positive one. So to summarize, that mast tryptase only protease phenotype of mast cell, they are located mainly in the mucosal tissue, and they are clinically important for allergic rhinitis, asthma, food allergy. Whereas the both tryptase and kinase positive, they are located not only on the skin and connective tissue. They are the responsible phenotype for mastocytosis and chronic inflammation production. And these are the important receptors over mast cell, and I think all of us know the typical mechanism of type 1 hypersensitivity reaction and the importance of that Fc epsilon receptor type 1, which is present on the mast cell where the Ig sits. So they are the high affinity Ig receptor, which triggers the degranulation on the allergen cross-linking. And this is important for us when we talk about mast cell disorders. The KIT receptor or CD117 receptor, they binds to SCF, and they are the essential for mast cell development. And there are multiple anaphylatoxins, neuropeptide, cytokines, toll-like receptors, uh, which detect microbial signals, and they are also do certain reactions, and they play their role on the mast cells, and they have specific receptors on it. And when we talk about function, it is beyond allergy. It is not only allergy, which is the which we can see the mediators like histamine, tryptase, or leukotrienes perform. But apart from muscles are important for wound healing, neuroinflammation, immune modulation, and antimicrobial defense system. So the clinical insight, as of now, what we had learned, the muscles are not exclusively IG driven. So they respond to multiple other factors like emotional stress, drugs, infections, physical triggers. So this non-IG mediated activation is clinically critical, especially when we talk about systemic mastocytosis and mast cell activation syndromes. This is a beautiful picture taken from a article published at NEGM. The mast cell activators, be it allergens to different types of viruses and lots of drugs, fungi. So what they do, they act on the mast cells, and via different type of mediators, they exert symptoms system specific. For an example, in cardiovascular system, they will produce hypotension, syncope, lightheadedness, tachycardia. In cutaneous system, they will produce flushing, pruritus, urticaria, angioedema. In the digestive system, they will produce abdominal cramps, diarrhea, esophageal reflux, nausea, vomiting. Musculoskeletal system, they will produce aches, bone pain, and we know the complication of muscle disorders, the mastocytosis, that is the osteoporosis, and the patient may present to endocrinologist to with osteoporosis, but actually the mast cell is the the, the problem causing agent. So that is why we can see the lot of system can be involved by mast cell disorders, and this is why the interdisciplinary management is very important for mast cell activator mediated disorders. There are systemic symptoms like fatigue, generalized malaise, weight loss, respiratory symptoms, neurologic symptoms, as mentioned here. And here we can see the factors, different types of drugs. For an example, the NSAID, vancomycin, very common. They do the direct stimulation to the mast cell, and they trigger the mast cell, and therefore the next step that had been produced by mast cell mediators. And apart from that, there are environmental factors, cytokines and growth factors, and peptides, different types of peptides. This is little bit we need to understand what is KIT and their role in pathophysiology and mutation. So they are a type 3 receptor tyrosine kinase. So this is a tyrosine kinase type of receptor, which is encoded by KIT gene on chromosome 4q12, and they expressed on mast cell, hematopoietic stem cells, melanocytes also, and germ cell. And the ligand here is the SCF, the stem cell factor. Now, when the stem cell factor bind with this receptor, there is a dimerization. The autophosphorylation will take place, and there will be downstream signaling, as mentioned here. Also, it includes the JAK-STAT pathway. There are multiple oncogenic KIT mutations in this game and this mastocytosis. These are few examples, important examples where we can see how the D816V, the ligand independent activation results in 90% of systemic mastocytosis cases. And there are other examples that had also been shown here. So there are also probability of KIT independent mutations, and that is why we need to remember them as an important differential diagnosis. So for an example, the eosinophilic myeloproliferative disorders or different type of myeloid neoplasms with muscle involvement. They mimic the systemic mastocytosis but are responsive to imatinib, unlike that D816 variant uh, positive mutation with systemic mastocytosis. So, what are the important clinical points here? As we talk about D816V mutation, which leads to constitutive KIT activation and promote uncontrolled mast cell proliferation, mediated release, therapeutic resistance to imatinib, and if there is a mutation detection with ASPCR or digital PCR, that is important for diagnosis, prognosis, and therapy selection. And there are US FDA approved therapeutics like avapritinib, midostaurin, and they are designed to inhibit the KIT D816V. I don't have any experience with this type of drug, but I think this is available in US. In India, the condition, I don't know about this availability. This mutation is cornerstone in both the classification and management of systemic mastocytosis, and that is why this mutation, we need to remember this number 816V, D816V. To simplify the mast cell disorders, if we want to classify, this is a simplistic classification. The cutaneous mastocytosis, primarily skin-limited mast cell proliferation, common in children, often self-limiting. And there could be certain subtypes. For an example, it is the most common form, Urticaria pigmentosa, previously known as, or currently it is also known as maculopapular cutaneous mastocytosis. Apart from that, it could be diffuse cutaneous mastocytosis, very common in much younger children, in infant. There are blistering, extensive skin thickening. And another subtype is solitary cytoma, that is a one lesion, and that is also present in infants. So when we talk about systemic mastocytosis, multi-system mast cell infiltration, if we want to understand, there could be different type of subtype. We will talk about this criteria later, but just to understand, when there is involvement of the skin and mild systemic symptoms, that is indolent systemic mastocytosis, where the muscle burden is very high but no organ failure, so that is a smoldering systemic mastocytosis, but with organ dysfunction without other hematologic neoplasm, then we can call it as aggressive systemic mastocytosis. And when there is different type of associated hematologic neoplasm, that is called as systemic mastocytosis associated with hematologic neoplasm, and that is a one leukemic variant is there, very rare but very poor prognosis, mast cell leukemia. Coming to this part, mast cell activation syndrome, clinical signs of mast cell mediator release without overt proliferation. So it could be primary, the clonal mast cell activation syndrome, where the KIT mutation will be there with abnormal mast cells. The secondary, generally, we see in case of different type of IG-mediated disorders, allergies, infections, etc., and very rarely certain oncologic conditions, cancers also can cause this secondary mast cell activation syndrome. Idiopathic mast cell activation syndrome, there are no identifiable driver present, so we need to diagnose by exclusion. And this case also, especially when we have idiopathic anaphylaxis, we need to be very much aware of this condition, that is idiopathic mast cell activation syndrome. This is an important hereditary condition, genetic disorder, where TPS-AB1 copy number increased, elevated basal serum tryptase level happened, and this is called as hereditary alpha tryptasemia. So may coexist with my muscle activation syndrome or systemic mastocytosis. The symptoms are again very common if you have a aggravated muscle function, uh, muscle mediators, then we will have this flushing, anaphylaxis, GI dysfunction. And this patient often suffered from postural orthostatic tachycardia syndrome. So why classification is important? Because this can guide us in risk stratification, genetic testing, therapeutic decision making, and particularly distinguishing between indolent and aggressive systemic forms, or diagnosing the muscle activation syndrome versus systemic mastocytosis. So if we want to understand the detailed classification, this is the list you can see in the screen, where we will get the details of different types of muscle disorders, starting with mastocytosis to mast cell activation syndrome to idiopathic anaphylaxis to reactions by Hymenoptera venom and clonal mast cell disorders, bone marrow mastocytosis, hereditary alpha tryptasemia, and combined, any combination of above conditions. So, clinical manifestations of mast cell disorders, as we had mentioned, in the skin, it could be urticaria pigmentosa, some maculopapular rash. In gastrointestinal tract, it could be cramping, diarrhea, acid hypersecretion, peptic ulcers, bone. We will get osteopenia and pathologic fractures. Neurological conditions like headache, brain fog, especially cognitive slowing, cardiovascular, hypotension, anaphylaxis, syncope, liver spleen, we will get hepatomegaly, elevated liver enzymes, and fibrosis also. The thing is that here I want to mention, because after COVID, there is a theory that also aggravate the muscle activity, and there is one case I can share with you all, though due to lack of due to difficulty in affordability, the patient had not done the necessary test, but the symptoms of brain fog, the cognitive slowing, that primarily diagnosed due to COVID. But when uh, we see the all the symptoms of starting from the gastrointestinal tract to urticaria pigmentosa, then we were clinically suspecting muscle disorders. But unfortunately, due to uh, the the cost of the test, the patient had not performed any prescribed test, including the tryptase level. So we need to understand there are certain conditions that can mimic muscle disorders, and we know very recently we had lost one a celebrity who due due to this Cownie syndrome. And apart from that, this is a list by which we can have this type of condition can mimic muscle disorders. But if we found some patients who are having overlapping condition, then we need to think about muscle disorders, and we need to rule out muscle disorders. So symptom severity often correlates with muscle burden, the number or of the cells into the tissues they infiltrated, and the mediator release. It could be histamine, tryptase, leukotrienes, and baseline tryptase value can support diagnosis, but it does not always correlate with severity, that we need to remember. And sometimes it may be absolutely normal when we are dealing with cases like muscle activation syndrome or hereditary alpha tryptasemia. So the key clinical insight for us should be symptoms are often non-specific, mimicking, for an example, IBS, anxiety, allergic rhinitis, chronic fatigue, fibromyalgia. So high index of suspicion is needed here when we are facing with multi-system and episodic cases. So, what is the diagnostic algorithm for muscle disorders? As we were mentioning about systemic mastocytosis, WHO had laid down this diagnostic criteria. So, major criteria: one or more plus one minor, or if we have three or more minor criteria, then we can call it as systemic mastocytosis. So major criteria is the multifocal dense infiltrate of 15 or more mast cells in bone marrow or any extracutaneous tissue. For an example, GI, mucosa, liver, spleen, etc. And the minor criteria, the atypical mast cell morphology, KIT D816V mutation, aberrant surface markers, especially the CD2 and CD25, and elevated serum tryptase level more than 20 nanogram per ml, that is persistently in the absence of any other myeloid neoplasm. This is what we were discussing, the criteria for diagnosis of systemic mastocytosis. And these are a few important diagnostic workup tools. We need to do serum tryptase, both the baseline and the episodic, which is a marker of both the burden and activation. Bone marrow biopsy is important to confirm the dense mast cell clusters, their morphology, the KIT mutation analysis, then the immunophenotyping, and TPSB1 gene testing. For allergy therapeutic specialist, uh, I think this fast test is important for us, and then we need to, if we are suspecting this type of cases, so also we need to take help from our hematology and oncology colleague. So this is important. And uh, REMA score, for an example, there are multiple validated score. And if this score, we can see the gender, clinical symptoms, and tryptase value with them, with this, we can get one score. And if it is more two or more, then we are most probably dealing with clonal muscle activated disorders. And that is why what we need to combine the histologic, molecular, and clinical data. And there is no way with this molecular testing is important, KIT D816V, which is essential for precision treatment. And uh, we need to think about hereditary alpha tryptasemia and mast cell activation syndrome. Uh, we need to exclude them before confirming the systemic mastocytosis. Now, what is this mast cell activation syndrome? These are the episodic systemic symptoms. So first of all, they will have systemic symptoms in an episodic way due to inappropriate mast cell activation, often without overt mast cell proliferation. That is not systemic mastocytosis. And these three criteria we need to remember. One, of course, the symptoms involving more than two or more than two organ systems. It could be skin, GI, cardiovascular, respiratory, or neuropsychiatric. And the biochemical confirmation also need to be done. The serum tryptase elevation during the episode must follow the 20% and 2+2 rules. And the timing is very important. When to do with the episode, the timing, the lag time is within 4 hours. That will give us the best result. And uh, this is important. Tryptase level during event must exceed at least 1.2 times of the baseline plus 2 nanogram per ml. And there should be clinical improvement with mast cell directed therapy. That is the third criteria. The histamine, chromoline, leukotriene antagonist, and anti-IgE omalizumab. So in nutshell, what we understand to diagnose mast cell activation syndrome, one is the symptoms of mast cell activation, then is the elevated mediators, that is tryptase level, at least 20% elevation, plus 2 microgram, and the response to therapy. So acute onset of symptoms that should involve at least two systems. So again, if we have the KIT mutation, that also define the clonality. So in a simple way, if we want to classify mast cell activation syndrome, one is the clonal mast cell activation syndrome, where the KIT mutation is present, maybe indolent systemic mastocytosis variant. The secondary mast cell activation syndrome, as we had discussed, it can be triggered by allergy, infection, autoimmune disorders, and idiopathic mast cell activation syndrome. They meet the criteria, but no trigger or clonality identified. So, when we talk about mast cell activation syndrome, it is underdiagnosed. It often mimics allergy, IBS, POTS, fibromyalgia, anxiety, panic disorders. So we need high clinical suspicion and structured diagnostic approach. And this hereditary alpha tryptasemia, which is the autosomal dominant genetic trait, and we had talked about it, the cause of it, increased copy number of that particular gene of TPS AB1 gene, which encodes alpha tryptase and leading to elevated basal serum tryptase level. So they often overlaps with mast cell activation syndrome, postural orthostatic tachycardia syndrome, and Ehlers-Danlos syndrome. There could be episodic flushing, pruritus, syncope, hypotension, bloating, diarrhea, and anaphylaxis, often triggered by stress, heat, or unknown. So, what are the key diagnostic insight? The baseline serum tryptase level is around more than 8 or 10 nanogram per ml. No KIT D816V mutation here. The symptoms are multisystem and episodic, and we need to confirm it with TPS AB1 gene copy number testing. So in this slide, how we can incorporate the REMA score, and another is ECNM score, by which we can have a clue on cutaneous mastocytosis or systemic mastocytosis. This is very, very important. And if we have this KIT D816V mutations, I think then we need to consider and bone marrow studies, and then with the bone marrow studies we will get more definitive diagnosis. So when we have suspected mastocytosis in adults, uh, then we need to check the tryptase value. If the tryptase value is less than 10, then we can have a follow-up. But increase in tryptase or clinical symptoms or signs that suggest the presence of mastocytosis, then we need to consider the bone marrow studies and staging if required. If the tryptase value is less than 10, but the REMA score is more than 2, then we need to think about other clinical symptoms. We need to ask different other type of clinical symptoms which we may miss, and whether the KIT D816V detectable in peripheral blood cells or not. If it is no, then we can have a follow-up. If it is yes, of course, we need to do the bone marrow studies. Same thing we need to do when the serum tryptase level is between 10 to 14.9. But here is, as we had shown, if it is more than 10, there is a possibility of hereditary alpha tryptasemia, and there we need to do the test. And therefore, if it is positive, then we need to do the follow-up, because there could be a overlap also. So we need to think about that. So whether we need to do the bone marrow study or not. And if it is negative and the serum tryptase level is between 15 to 30, then obviously we need to plan for bone marrow studies and staging. And tryptase value more than 30, we need to plan for bone marrow studies and staging investigations. So if we want to talk about one algorithm for evaluation of possible mastocytosis, this is from NEJM paper published in 2016. I think this is very useful for us who are not practicing in the field of hematology or in the field of oncology, but as allergologists, we can have this flow in front of us and we can plan accordingly. So patients with symptoms consistent with mast cell activation, that could be obtained through medical history. That includes reaction to foods, medication, radiographic contrast mediums, insect stings, latex, temperature, and stress. Then we need to assess the patient's response to exercise and also some skin examination. Then go for the tryptase value, and there could be two possibility. One is if it is less than 10, then it's okay. But then also, if the basal serum tryptase level is normal, less than 10, or slightly elevated, between 20, uh, increased with symptomatic event, or both, then we need to do something more that I'm coming later. Other possibility could be basal tryptase level is more than 20 nanogram per ml, and event-related tryptase level increased by 20% above baseline level plus 2 nanogram per ml, or both. So event-related means that the temporal relationship within 4 hours of that particular event. There, if it is there, we need to do the bone marrow biopsy, and we need to screen for that KIT mutation. We need to advise them to do that. But if the basal serum tryptase level, as we had mentioned, is normal or slightly elevated, increased both with a symptomatic event or sometimes that that time we need to measure whether it is mast cell activation syndrome or not due to allergy. So measure total and allergen specific serum Ig. If patients has history of anaphylaxis to Hymenoptera stings, hypotensive anaphylaxis documented with or without angioedema or urticaria. If it is there also we need to plan for screening D816V KIT mutation in peripheral blood. If skin lesions are present, do the skin biopsy, and if it is cutaneous mastocytosis, we found from the skin biopsy, then consider for the bone marrow biopsy in adults, and it is rarely required in children, the bone marrow biopsy. So after having the bone marrow biopsy and screening for that D816V KIT mutation, we can understand whether this is a systemic mastocytosis or if it is not a systemic mastocytosis. Even if it is then there is no systemic mastocytosis, we need to sometimes measure the 24-hour urinary measurement of the metabolites of mast cell mediators, mostly the methylhistamine, prostaglandins, and the specific 11 beta PGF2 alpha level. That also tell us about the status of mast cell activation. And as we had already discussed, the cutaneous mastocytosis, generally we need to consider the bone marrow biopsy in adults if clinically indicated, but rarely it is required in children. So how to manage? Finally, how to manage the mast cell disorders? Of course, we can provide this supportive management. For example, H1 antihistamine for pruritus flushing symptoms, H2 antihistamine for GI acid related distress, the leukotriene receptor antagonist, montelukast, because that will also mediate those leukotriene mediators and provide us symptoms control. The sodium cromolyn, which is a mast cell stabilizer, this was found to be very much helpful in GI symptoms. And epinephrine auto-injectors, the training of using epinephrine need to be provided when there is patients with mast cell activation syndrome or the systemic mastocytosis. Sometimes in case of urticaria pigmentosa or cutaneous mastocytosis, so we need topical corticosteroids. These are the advanced or targeted therapies. Uh, they are the midostaurin, the multikinase inhibitors. They block that D816V gate, and therefore they can be used in advanced systemic mastocytosis. Another KIT 816V inhibitor is avapritinib. They are also approved for advanced systemic mastocytosis, improved mediator symptoms. Interferon alpha 2b, cladribine, they are helpful in cytoreduction, especially in aggressive and refractory systemic mastocytosis. The allogenic bone marrow transplant, which could be considered in mast cell leukemia or resistant cases. This is very important for patient education. The trigger should be avoided. Alcohol, NSAIDs, opioids, temperature extremes, stress, and radio contrast agent. So when you talk about management, it should be tailored based on the phenotype, burden, and risk. And we need to integrate the supportive plus cytoreductive strategies where indicated. Finally, what is the prognosis and how to do the monitoring in muscle disorders? The cutaneous mastocytosis, they had excellent prognosis. Very rarely they progress systemically. Indolent systemic mastocytosis, yes, it is a chronic course, but normal life expectancy. Uh, we need to manage it with conservative management, conservative therapy, because of the problems arises with the symptom burden and the quality of life often affected. And when we talk about this systemic mastocytosis with associated hematologic neoplasm or aggressive systemic mastocytosis, which is the domain of the hematologist, we need to early refer them to the hematologist and oncologist. They have a variable survival, 2 to 4 years, depending on the mutation load and the cytoreduction response. And we know that mast cell leukemia is something which is having a very poor prognosis, and median survival is less than 12 months despite therapy. And these are the case, the hematologist and oncologist, they are the best person to treat them. The monitoring strategy should be, of course, the baseline and serial tryptase level can help. Organ involvement, we need to check the liver function, the status of fibrosis of the liver, spleen size, GI lesions. Sometimes we need to do the colonoscopy or endoscopy. Bone marrow, the cellularity, the muscle aggregates, the fibrosis, the molecular markers. For an example, we had discussed about the KT1 D816V allele burden. This can be checked, and additional mutations for high risk features. So progression risk is there with indolent systemic mastocytosis to advanced or aggressive systemic mastocytosis and mast cell leukemia. And this risk increases with age, kids' allele burden, and multi-lineage involvement. So we need to do the follow-up. We need to refer these cases to hematologist and oncologist. They need to monitor the different type of molecular evolution, early detection of transformation that can aid the treatment timing. So this is a case study from our clinic, that 4-year-old male, persistent itchy rash since age 2, no systemic symptoms, no flushing, no syncope, no GI complaints, no prior anaphylaxis. In the skin, what we had found, some multiple tan brown maculopapular lesion, and the Terrier sign was positive. So local urticaria on rubbing. So that is called as Terrier sign. And if you just rub, and you will get the local urticaria, and it could be easily elicited during your clinical examination. So physical examination, no hepatosplenomegaly, no lymphadenopathy. The tryptase level was normal. Uh, so the patient was being advised previously. So we get this report that there is the KIT D816V mutation. It was not detected, and the skin biopsy was negative for CD2 or CD25 expression also. So diagnosis is clear cut. It is maculopapular cutaneous mastocytosis. So management was topical corticosteroid for each and non-sedating H1 antihistamine. We had used the fexofenadine, and the patient education is very important, how to avoid the triggers. Epinephrine also, because that is a precaution. If anaphylaxis happen, we may have an anaphylaxis action plan discussion with the patient. So regular monitoring for signs of systemic involvement, this has excellent prognosis. Majority outgrows the cutaneous mastocytosis during adolescence. So to summarize, mast cell disorders span from benign cutaneous mastocytosis to fatal mast cell leukemia phenotypes. This mutation is central to the pathogenesis of systemic mastocytosis, the KIT D816V mutation. And when we want to talk about diagnosis, for diagnosis, we need tryptase value, we need to understand the KIT mutation and the polyclonal expression, especially the CD2, CD25 marker. Yes, we need to understand and acknowledge that hereditary alpha tryptasemia is under-recognized in our allergy clinics. We need more training on that, how to diagnose them early. And now we have precision therapy for advanced systemic mastocytosis. For an example, we have midostaurin or avapritinib. So thank you all. Mast cell disorders require a high index of suspicion, multidisciplinary input, and tailored management for optimal outcome. In India, we need to develop one registry on mast cell disorders, and I think this is the need of our. And 20th October is the Mast Cell Disease Awareness Day, the mastocytosis. And I am really thankful to Dr. Neeraj Gupta, who had given me this topic on mast cell disorders. And my birthday is coinciding with 20th October too. So I am really thankful to Dr. Neeraj Gupta for giving me this topic to deliver in this prestigious uh, podium of paid Allercon 2025. Thank you all.